let's talk about the important points in anatomy of the female reproductive tract, which you have to know. First, we are going to talk about the fallopian tube. So in the fallopian tube, first thing is the length of the fallopian tube. Length of the fallopian tube is between 10 to 12 centimeters. A next very important point which they ask you is from medial to lateral, what are the parts of the fallopian tube? So from medial to lateral, the parts of the fallopian tube are interstitium, then isthmus, then ampulla and infundibulum. Very important. First, medially is interstitium, then isthmus, then ampulla and then infundibulum. Remember, interstitium is also called as the intramural part. Right? Now, interstitium is the narrowest part of the fallopian tube and it is the anatomical sphincter. It is the rarest site for ectopic pregnancy, and when ectopic pregnancy occurs in the interstitium part, it is called as the cornual ectopic. Now, if ectopic pregnancy occurs in the interstitium, that is the cornual ectopic, then it lasts for a very long time here. See, although logic says that because interstitium is the narrowest part, the ectopic pregnancy should end very soon. But it's the other way around. In interstitium, the ectopic pregnancy lasts for a very long time. That is because myometrium of the uterus supports the ectopic pregnancy in the interstitium. That is why in the tubes, ectopic pregnancy lasts for the longest time in the interstitium. Overall, ectopic pregnancy lasts for the longest time in abdomen, right? So abdominal ectopic pregnancy lasts for the longest time, but in the tubes, it is the interstitium in which the ectopic pregnancy lasts for the longest time. Now, because in the interstitium, it is the myometrium which is supporting the ectopic pregnancy. So when ectopic pregnancy ruptures in the interstitium, then it leads to a lot of bleeding, and that is why it is the most dangerous site for ectopic pregnancy. And a question which was asked in the MCI exam, that which is the most dangerous site for ectopic pregnancy, it is the interstitium, right? Then let's talk about the isthmus. Isthmus is the second narrowest part. It is the site for tubal ligation. So tubal ligation is performed in the isthmus. Isthmo-isthmic anastomosis is best for reversal of tubal ligation. So if they ask you for reversal of tubal ligation or for recanalization, what is the best? Best is isthmo-isthmic anastomosis. Ectopic pregnancy ends the earliest in isthmus because it is the second narrowest part, right? It acts like a physiological sphincter. So anatomical sphincter was your interstitium and physiological sphincter is the isthmus. Clear? Now let's talk about the ampulla. Ampulla is the widest part of the tube and it is the most common site for fertilization. It is the most common site for ectopic pregnancy. It is the most common site for genital TB and it is the most common site for tubal abortion. So ectopic pregnancy, when it ends as abortion, that is called as tubal abortion, and it is the most common site for tubal abortion, right? That is what you have to remember from the ampulla. As far as the infundibulum is concerned, nothing special to be remembered in infundibulum. Just remember that from medial to lateral, it is interstitium, isthmus, ampulla and infundibulum. Now, the fallopian tube is lined by ciliated columnar epithelium and it has got special cells which are called as the PEG cells, right? Function of these PEG cells is not known, but this question is very, very oftenly asked. Blood supply of fallopian tube. Medially, fallopian tube is supplied by the uterine artery and laterally it is supplied by the ovarian artery. Clear? So these are the important points on fallopian tube which you had to remember. Now let's talk about the important points which you have to remember on the uterus. First thing what you have to remember about the uterus is the supports of the uterus, which we have already dealt in the chapter on prolapse when I was talking to you about prolapse. So next thing which you have to remember is that cervix is longer than the uterus before puberty. So if they ask you what is corpus cervix ratio, corpus stands for the body of the uterus, right? So if they ask you what is corpus is to cervix ratio, you are going to say in childhood, because cervix is longer than the uterus, this ratio is 1:2. So be very careful whether they are asking you corpus is to cervix ratio or cervix is to corpus ratio. Corpus is to cervix ratio in childhood is 1:2. At puberty, this ratio becomes 2:1. In reproductive age, this ratio becomes 3:1. And at menopause, both uterus and cervix will atrophy, and this ratio becomes 1:1. Clear? Okay. Now, in uterus, you also have to remember the parts of the uterus. Now, if you look at the uterus over here, this is the diagram of a uterus, which I've drawn really bad. Okay, so this angle over here, let me draw it a little properly. Oh, see. This angle over here, the angle of the uterus is called as the cornua. The part of the uterus which lies above the angle, that is called as the fundus. Then you have the body or the corpus. And over here down, we have the internal os, right? So internal os means the place where uterus is opening into the cervix. Now, actually speaking, there are two internal osses, anatomical internal os and histological internal os. Anatomical internal os is where, as per anatomy, uterine cavity is changing into the cervical cavity. That will be called as anatomical internal os, or normally called as the internal os. Now, it is not necessary that the lining of the uterus, or that is the endometrium, it changes into the lining of the cervix exactly at the anatomical internal os. This happens a little below. So the place where the lining of the uterus, it changes into the lining of the cervix, that is called as the histological internal os. Right? So we have an anatomical internal os which will lie a little above, and below that will be histological internal os. Now the part of the uterus which lies between the anatomical internal os and histological internal os is called as the isthmus. Very important point about isthmus is that isthmus forms the lower uterine segment during pregnancy. The length of the isthmus in non-pregnant females is just half a centimeter, 0.5 centimeters. In pregnancy, isthmus forms the lower uterine segment and the size of the isthmus becomes 5 centimeters. At the time of labor, if they ask you what is the length of the lower uterine segment, see, at the time of labor, the entire cervix is taken up. Right, so it is in the lower uterine segment at the time of labor is not only composed of isthmus, it is also composed of the cervix. Right, so 5 centimeters lower uterine segment plus 4 to 5 centimeters cervix comes. So at the time of labor, the length of the lower uterine segment is 10 centimeters. Very, very important questions which you have to remember. Now, we were talking about the cornua, or the angle of the uterus. Now, at the angle of the uterus, there are three very important structures which are attached. From anterior to posterior, these structures are R, P and O, right? So R, P, O. So this over here is O. So in RTO, R stands for the round ligament, T stands for fallopian tube, O stands from ovarian ligament, and this is from anterior to posterior, and this is very, very important for all your image-based questions, right? So if they mark any of these structures as X and they ask you to identify, you can see from anterior to posterior, it is round ligament, fallopian tube and ovarian ligament. Now, because three tube-like structures are attached to the cornua of the uterus, that is why at the time of tubal ligation, instead of ligating the tube, a gynecologist can ligate the round ligament or the ovarian ligament. So if someone asks you what is the most common cause of failure of female sterilization, your answer will be identification of wrong structure. Right? Now let's talk about the blood supply of the uterus. Blood supply of the uterus it is supplied by uterine artery. Uterine artery is a branch of the anterior division of internal iliac artery, and it is also supplied by branches of ovarian artery. Right? Now, suppose the question comes that there is a female who's having intractable PPH and you've tried all the medicines, the bleeding is not getting controlled. Which vessels can you ligate to decrease the bleeding? You are going to say all the vessels which supply the uterus can be ligated. In other words, you can ligate uterine artery, then you can ligate the ovarian artery, and because uterine artery is a branch of the anterior division of internal iliac artery, third artery which you can ligate is the internal iliac artery, the anterior division. right? So this is what you had to know on uterus. Now, about uterine artery, there are a few important points which you have to remember. See, uterine artery is the main artery which supplies the uterus, and when it gives branches to the uterus, these branches from outside to inside you have to arrange. And this was a question of MCI, that what are the branches of the uterine artery to the uterus from outside to inside. So from outside to inside, you can remember it by a mnemonic U Arabs, right? U Arabs, where U stands for uterine artery. And then the branches are ARBS, where A stands for arcuate artery, R for radial artery, B for basal artery, and S for spiral artery. So from outside to inside, the branches are UARBS. A for arcuate, R for radial, B for basal, and S for spiral. Now, apart from giving branches to the uterus, uterine artery also gives a Sampson artery to the round ligament. So, round ligament is also supplied by uterine artery, but which branch of uterine artery? The Sampson artery, right? A very, very important point to note over here is, suppose this over here is the internal os, and I'm talking about anatomical internal os. Whenever they say internal os, it means it is anatomical internal os. Now, 2 centimeters lateral to the internal os, over here is present the ureter. The ureter was coming like this, right? Now, 2 centimeters lateral to the internal os, the uterine artery crosses the ureter and then it goes up and it supplies the uterus. Right? So this point over here is called as water under bridge. So uterine artery crosses the ureter 2 centimeters lateral to internal os, and this is called as water under bridge, where water is the urine in the ureter. And this is the most common site of ureteric injury during hysterectomy. Right? Very, very oftenly asked question, that what is the most common site for ureteric injury during hysterectomy? It is 2 centimeters lateral to the internal os. Right? Now let's talk about the cervix. Now in cervix, there is endocervix and there is exocervix. So if you look at the diagram over here, this over here is the uterus and this over here is the cervix, right? Now, this part of the cervix, which is lying closer to the uterus, is endocervix, and the part of the cervix, the orange colored part, which I have shown here, which is lying within the vagina, is exocervix. Because exocervix lies within the vagina, it is also called as the portio-vaginalis part, and the endocervix is called as the supravaginal part. Endocervix is lined by columnar epithelium. Exocervix is lined by the stratified squamous epithelium, right? Now, the place where columnar epithelium of endocervix changes into stratified squamous epithelium of exocervix, that is called as transformation zone, which I have shown in green color here, right? So, the place where the columnar epithelium of the endocervix is changing into the squamous epithelium of exocervix, that is the transformation zone or the squamo-columnar junction, right? The transformation zone or the squamo-columnar junction. Now, the place where cervix is opening into the vagina, that is called as external os. So, the blue color which I have marked is external os. It is the place where cervix opens into vagina. The place where uterus opens into cervix, that is the internal os, right? Now, what you have to remember is that if they ask you what is the most common site for cancer cervix, it will be transformation zone or the squamo-columnar junction. Why? Because this is the place where one epithelium is changing into the other epithelium. If they ask you what is the most common variety of cancer cervix, now because at the transformation zone, the columnar epithelium is changing into squamous epithelium. So the most common variety of cancer cervix is squamous cell carcinoma, and the most common variety in squamous cell carcinoma is the large cell keratinizing variety. So I agree that the most common cancer for cervix is the squamous cell carcinoma. But if you see, the endocervix is lined by columnar epithelium right? This means adenocarcinoma can also happen in the cervix, although that's not the most common, but adenocarcinoma can happen. So if they ask you what is the most common site for adenocarcinoma of the cervix, your answer will be endocervix. But if they are simply asking you most common site for cancer cervix, then it is transformation zone. Right? Now, in cervix, you have to remember that the length of the cervix is 2.5 centimeters in a non-pregnant female, and it is roughly 4 to 5 centimeters during pregnancy. Right? Then, the lymphatic drainage of cervix, very, very important. Lymphatic drainage of cervix, it can be remembered by a mnemonic HOPE, where H stands for hypogastric lymph nodes or the internal iliac lymph nodes. O stands for obturator lymph nodes. P stands for presacral or paracervical or ureteric lymph node. And E stands for the external iliac lymph nodes. Right? Now, why I'm saying lymphatic drainage of cervix is very important is because many questions are asked based on the lymphatic spread of cancer cervix. So if they ask you which is the most common lymph node involved in cancer cervix, the most common lymph node involved in cancer cervix is obturator lymph node. The first lymph node involved in cancer cervix, that is the sentinel lymph node for cancer cervix, it is the ureteric or the paracervical lymph node. Right? And the lymph node which is not involved in cancer cervix are the superficial inguinal lymph nodes, right? Because cervix doesn't drain into the inguinal lymph nodes. So by lymphatics, never will the superficial inguinal lymph nodes be involved in cancer cervix. So suppose in a patient of cancer cervix, superficial inguinal lymph nodes are involved. What does that mean? That means that the cancer has metastasized. So whenever superficial inguinal lymph nodes are involved in cancer endometrium or cancer cervix or cancer ovary, 100% it means it is stage 4B. So in all these three cancers, involvement of inguinal lymph node means stage 4B, that is metastasis, distant metastasis. If pelvic lymph nodes are involved in endometrial cancer or cancer cervix, then it means it is stage 3C1. Earlier, there wasn't any stage 3C in cancer cervix, but the new staging of cancer cervix includes stage 3C1 and 3C2. 3C1 means pelvic lymph nodes are involved. 3C2 means para-aortic lymph nodes are involved. And this is same in cancer cervix as well as in endometrial cancer, right? So this is what I wanted you to remember about the cervix. Now let's talk about vagina. In vagina, the most important point to remember is that vagina has inhabitant bacteria which are called as the dodeline bacilli. These dodeline bacilli are lactobacilli which convert the glycogen of the vaginal epithelium into lactic acid. That is why the pH of vagina is acidic, right? Now, these dodeline bacilli, they appear at puberty and they disappear after menopause. So, if someone asks you, what is the pH of vagina in childhood? In childhood, there is dodeline bacilli. That is why in childhood, the pH of vagina is alkaline between 6 to 8. Similarly, if they ask you what is the pH of vagina after menopause, again after menopause the dodeline bacteria will disappear. So again pH of vagina is alkaline, that is 6 to 8, right? At puberty, because dodeline bacilli will appear, so the pH of vagina will change from alkaline, it will become acidic. And how much acidic? So much acidic that at reproductive age it becomes 4.5. Now, at the time of menstruation, remember that the pH of blood is alkaline. That is why at the time of menstruation also the pH of vagina is alkaline and it is between 6 to 8. Now, during pregnancy, the number of lactobacilli, that is the number of dodeline bacilli, will increase. And if the number of dodeline bacilli will increase, more glycogen will get converted into lactic acid. And so the pH of vagina decreases in pregnancy and it becomes more acidic. It becomes 3.5. Range is between 3.5 to 6, right? Vagina is lined by stratified squamous epithelium. A very important point about vagina is that it doesn't have any glands. So when we say that there is vaginal discharge present, actually that discharge is coming from mainly from the cervical glands, then from the endometrial glands, and at the time of intercourse from the Bartholin gland. The lymphatic drainage of vagina, upper one-third of vagina, it drains into same lymph nodes like the cervix, that is, it is HOPE. Middle one-third drains into internal iliac lymph nodes, and lower one-third of vagina drains into superficial inguinal lymph nodes. Right? So before I wrap up anatomy for you, just very important thing is, what is the nerve supply of the various organs? Uterus, the nerve supply is between T10 to L1. Cervix is between S2 to S4. Now, because the pain in labor, in the early stages of labor, pain is because of the uterine contractions, and that is why in early stages of labor, pain is limited to segments T10 to L1. Now, in the later stages of labor, pain is due to dilatation of the cervix. And because pain is due to dilatation of the cervix and the cervix nerve supply is S2 to S4, so in the later stages of labor, pain is in the segments S2 to S4. It is mediated by S2 to S4, right? So suppose a female comes to you and she says that she wants to have painless labor. Now, painless labor means you will have to take out the pain from early labor as well as from the late labor. And we know that if we put an analgesic in an upper segment, it will come down and the effect will go on all the lower segments also. So this means if I say that for painless labor, epidural analgesia should be given in which segment? It should be given at T10 segment, because from there the drug is going to come down and it is going to, analgesia will spread over all the lower segments, right? So uterus supply is T10 to L1, cervix is S2 to S4. In the early stages of labor, pain is mediated by segments T10 to L1. In the later stages, it is mediated by S2 to S4. For painless labor, analgesia should be given at T10 segments. And for cesarean section, the anesthesia should be given at T4 segment. Now, why T4 segment? Because the peritoneum also needs to be anesthetized, right? Now, external genitalia is supplied by pudendal nerve. That is, the vulva is supplied by pudendal nerve. So, if I am applying forceps or vacuum. Now, when you apply forceps or vacuum, pain is at the time of insertion and it is in the external genitalia. So, for instrumental delivery, I will have to take away the pain from external genitalia. In other words, I will have to do a pudendal nerve block. So, for instrumental delivery, you are going to go for a pudendal nerve block. Two very important questions on pudendal nerve block. Number one, what is the site for giving pudendal nerve block? The site for giving pudendal nerve block is the ischial spine, right? So this is the ischial spine where you give the pudendal nerve block, right? Next question on pudendal nerve pudendal nerve block which they ask you is that which ligament is pierced when you are doing a pudendal nerve block? The answer is sacrospinous ligament. So these are two questions which they ask you on pudendal nerve block, right? Then comes the nerve supply of vagina. See, upper part of vagina, it is supplied by the same nerves which supply the cervix, that is S2 to S4, and lower part of vagina is supplied by the same nerves which supply the vulva, that is the pudendal nerve. So this is about the nerve supply of the female external genital tract. Right? Now, in a similar manner, let's talk about infertility and the important points which you should be knowing about infertility. Right? Before I talk to you about infertility, it's important to know spermatogenesis, right? Because infertility, it can be due to the male partner or it can be due to female partner. Right? And in male partner, it's very important to first understand how spermatogenesis occurs and important points on spermatogenesis. Now, oogenesis, it began in intrauterine life, but spermatogenesis, it begins at the time of puberty. Spermatogenesis is dependent mainly on hormone testosterone, but it is also dependent on LH and FSH. Sperm, they attain motility in epididymis and especially in the caudal end of the epididymis. Time taken for spermatogenesis is 70 to 74 days. There is a term which is capacitation. Capacitation is the ability of the sperms to fertilize the ova, and capacitation occurs in the female genital tract. Capacitation is going to begin in the cervix, but maximum capacitation occurs in the fallopian tube. Time taken for capacitation is 6 to 8 hours. The size of sperm is 55 microns. Remember, the size of ova was 120 microns. Right, the fertilizable span of sperm is 48 to 72 hours. The fertilizable span for ova was 12 to 24 hours. Right? Now, all the germ cells, that is whether it was spermatogonia or whether it was oogonia, they originate from the epiblast. That's a very, very important question. Right? Now, whenever a couple come to you for infertility, first understand what is meant by infertility. Infertility is inability of a couple to conceive even after 1 year of unprotected intercourse. Now, if the female has never become pregnant, that is a case of primary infertility. And if earlier she had become pregnant, but now she's unable to conceive, that's a case of secondary infertility. Whenever a couple come to you with infertility, the first test which you do is semen analysis, because by doing semen analysis, you will come to know whether the problem is in the male or not. Semen analysis should always be done after an abstinence, that is after not having intercourse for at least 2 to 3 days. Right? Now, in semen analysis, the parameters which are important and which you have to remember is that the volume of the semen should be more than equal to 1.5 ml. Sperm concentration should be minimum 15 million per ml. This is the WHO criteria. Total sperm count should be more than equal to 39 million per ejaculate. So per ml, it should be more than equal to 15 million per ml. Per ejaculate, it should be more than equal to 39 million. Right? The motility. Now, in motility, you have to remember total motility should be 40% at least, and progressive motility at least should be 32%. Morphological number of sperms should be at least 4% in the semen analysis, and alive sperms or viable sperms should be at least 58%. This table is very, very important, right? Now, suppose on semen analysis, no semen was present. If no semen is present, the condition is called as aspermia. If there is less sperm concentration, it should be more than equal to 15 million per ml. But if the sperm concentration is less than 15 million per ml, it is called as oligospermia. Severe oligospermia means that the sperm concentration is less than 5 million per ml. Right, azoospermia means so there is no sperm in semen, that is called as azoospermia. No semen was aspermia. Now, if the motility of the sperms is decreased, the condition is called as asthenospermia. If the sperms are not morphologically normal, less than 4% sperms are morphologically normal, the condition is called as teratozoospermia. And if the number of viable sperms is less than 58%, it is called as necrozoospermia. Right? Okay. Now, a little bit more which you have to know about azoospermia is, in azoospermia, there is a variety which is called as obstructive azoospermia. In obstructive azoospermia, there is an obstruction in the passage of the sperm. See, spermatogenesis was happening in the testes, then the sperms went to the epididymis where they attained motility and maturity, and then via the vas deferens they have to come out. Now suppose there is a blockage in vas deferens. So whenever there will be a block in vas deferens, the sperms will be absent in semen. But in the testes and the epididymis, the sperms will be present because spermatogenesis is happening normally. So in a variety of azoospermia, which is obstructive azoospermia, although the sperms are absent in semen, but the sperms will be present in the testes. So this means if sperms are present in the testes, I can take out sperms from the testes or from the epididymis, and this couple can have their own biological child. So if I ask you which type of azoospermia has the best prognosis, you will say, ma'am, it's obstructive azoospermia which has the best prognosis, right? Now let's talk about the management of male infertility. Now, in management of male infertility, you have to remember that if sperm count is between 10 to 15 million per ml, Then the management of choice is IUI, that is intrauterine insemination. If sperm count is between 5 to 10 million per ml, then the management of choice is IVF, that is in vitro fertilization. If sperm count is less than 5 million per ml, in other words, there is severe oligospermia, or there is azoospermia, or there is asthenospermia. In these three conditions, if there is severe oligospermia, or if there is azoospermia, and which kind of azoospermia? Obstructive azoospermia, or if there is asthenospermia, then the management is ICSI. What is ICSI? Intracytoplasmic sperm injection, right? So now let's quickly talk about how IVF and ICSI are done. In both IVF and ICSI, to the female partner, you will give clomiphene citrate from day 2 to day 6. And why we are giving clomiphene citrate is so that she hyperovulates. Then from day 10 onwards, I'm going to do a special ultrasound, a TVS, which is called as follicular monitoring, in which my purpose is to see how the follicle is growing each day, right? Normally, a follicle increases in size by 2 millimeters per day. Now, once the follicle becomes 18 to 20 millimeters in size, then I am going to give injection HCG. It is this injection HCG which is similar to hormone LH, and it will trigger ovulation. So many times they ask you in clomiphene induced cycle, whenever you are giving clomiphene, which hormone is used for ovulation trigger? So it is injection HCG which is used as ovulation trigger. Now, once you've given injection HCG, you know that after LH surge, ovulation happens after 32 to 36 hours. Similarly, after giving injection HCG, after 32 to 36 hours, ovulation will happen. Once ovulation happens, that means the primary oocytes are getting converted into secondary oocytes. These secondary oocytes I'm going to pick up. So till now, the procedure was same, whether I was doing IVF or whether I was doing ICSI, intracytoplasmic sperm injection. Now, if I'm doing IVF, what I'm going to do is I'm going to pick up these oocytes, which I have marked over here with blue color, and I am going to put them in a petri dish. Per oocyte, I am going to take 50,000 to 1.5 lakh sperms, and I'm going to put it in the petri dish. So the fertilization is going to happen in the petri dish, and once the zygotes are formed, either on day 3 or on day 5, I'm going to put them back inside the uterus, right? So per oocyte in IVF, 50,000 to 1.5 lakh sperms are needed. But in case of ICSI, what I do is I pick up an oocyte, and into the oocyte, with the help of a syringe, I am going to put a single sperm. So that is why it is called as intracytoplasmic sperm injection. So in case of ICSI, per oocyte, you need only one sperm. So this is the reason why, if there is severe oligospermia, or if there is a obstructive azoospermia, in obstructive azoospermia, I can take out sperms from the testes or epididymis and I can go for ICSI. And in asthenospermia also I can go for ICSI, because in asthenospermia the motility of the sperms is decreased. In IVF, the sperms will ultimately have to swim and reach the oocyte, but in ICSI they don't even have to swim. I am putting it inside the oocyte, right? So in asthenospermia also you can go for ICSI. So many times this question has been asked recently, that what is the most important parameter in semen analysis? The most important parameter in semen analysis is morphology of the sperm. If morphology of the sperm is normal, you can perform ICSI. ICSI cannot also be performed, right? So the most important parameter is morphology, then it is motility, and then concentration. These are the points which you have to remember about male infertility. Now let's talk about female infertility. Now, in female infertility, number one cause can be anovulation. And as I told you in PCOS, that anovulation is the most easily treatable form of infertility, and the most common cause of anovulation is PCOS. Now, all the tests for anovulation, they are done on day 21 or day 22 of the cycle, because that is the time when, if the female is ovulating, her progesterone levels would have been the highest, right? If they ask you which is the best test for detecting whether a female is ovulating or not, in that case, the best tests are hormonal tests. Now, in hormonal tests, there are two types of tests. Number one, if you want to detect whether a female had ovulated or not, in that case, you check her serum progesterone levels on day 21 or day 22. And if on day 21, day 22, serum progesterone levels are high, that means, yes, on day 14, she had ovulated. But there will be many females who will be having irregular cycles. And in those females, you will need to predict when ovulation is going to happen. In such case, the best hormonal test is LH. Like we have pregnancy kits, we also have LH kit, which tell you that whether a female, when is the time when a female will ovulate. So best hormonal test to detect ovulation is progesterone. Best hormonal test to predict ovulation is LH. Drug of choice for anovulation is clomiphene citrate. But if they ask you drug of choice in PCOS patient, then it is letrozole. If the general question is drug of choice for anovulation, it is clomiphene citrate, right? Then a second problem which could lead to infertility in females is that the number of follicles in the ovaries decrease. And obviously, if the number of follicles in the ovary decrease, a female cannot conceive, and that is called as decreased ovarian reserve. Now, in order to test for decreased ovarian reserve, the best test is you should do anti-Mullerian hormone. See, from puberty onwards, granulosa cells of the ovary, they not only produce inhibin and estrogen, they also produce anti-Mullerian hormone. So if the number of follicles are less, the levels of anti-Mullerian hormone will also be decreased, right? And this test can be done on any day of the cycle, right? That is why it is the best test. Or what you can do is you can check FSH levels on day 3 of the cycle. Now, if the number of follicles are less, then there will be less estrogen. And if there will be less estrogen, the negative feedback on FSH will be gone. And so the levels of FSH will increase. So if on day 3, the levels of FSH are increased, and how much increased? More than 40 international units, like you say for menopause, then it means that yes, ovarian failure has occurred, right? If the levels are more than 20, then it means there is decreased ovarian reserve. Ovarian failure means that there are no more follicles. That means the FSH levels are more than equal to 40 international units. The problem with this test is that you have to do this test on day 3 of the cycle. Similarly, another test can be that with the help of ultrasound, you count the number of follicles, and that is called as the antral follicle. Now, in case of decreased ovarian reserve, the antral follicles will decrease. And again, this test has to be done on day 3 of the cycle, and that is why it is not the best test. Best test is you go for anti-Mullerian hormone because it can be done on any day of the cycle. Now, suppose if the number of follicles have decreased, I don't have any drug which can increase the number of follicles. In that case, the management will be, I will have to do IVF with donor eggs, right? Now, the third problem which could lead to female infertility is that there is a block in the fallopian tube. Now, if there is a block in the fallopian tube, then that is a tubal cause of infertility. And this block can be due to PID, it could be genital TB, salpingitis, endometriosis. All of them can lead to a block in the fallopian tube. Now, if there is a block in the fallopian tube and you want to know that whether the block is present or not, in that case, what you should do is you should take a cannula, and this cannula has a special name which is called as a Leach-Wilkinson cannula, right? So you will take a Leach-Wilkinson cannula, and from this cannula, you are going to pass a radio-opaque dye, right? I will pass a radio-opaque dye, and with the help of serial ultrasounds, I will see whether the dye is coming out or not, right? This test is called as HSG, hysterosalpingography. So in hysterosalpingography, with the help of this special cannula, Leach-Wilkinson cannula, so this Leach-Wilkinson cannula, it has a funnel-shaped proximal end and it will have lines like these. Right? Now, because I am passing a dye and I am doing an X-ray to see whether the dye is coming out or not. This test should always be done in the pre-ovulatory phase. That means between 7th to 10th day of the cycle. You should never do this test after ovulation has occurred, because so many times it will happen that the female would not be knowing she's pregnant. Even I wouldn't know she's pregnant. And if I pass a dye, then she will abort, right? So always this test should be done before ovulation, and the best time to do it is between 7 to 10 day of the cycle, right? Now, many times it is seen that when you do an HSG, you get a bilateral cornual block on HSG. So how are you going to get the image like? So this over here is the uterus. A block is present over here. So when the dye, you will see that the dye has gone only up till the cornua of the uterus and it has not gone any further. This is called as bilateral cornual block on HSG. Now, the most common cause of bilateral cornual block on HSG is physiological. When you are passing a dye because of pain, the cornual end of the tube, it undergoes spasm, and because of that spasm, the dye cannot pass any further. So the most common cause of bilateral cornual block on HSG is physiological spasm. The most common pathological cause is genital tuberculosis, right? With the help of HSG, you can see whether the tubes are blocked or not, but you cannot see the exterior of the tube. That is why the gold standard test is laparoscopic chromoperturbation. What do you do in laparoscopic chromoperturbation? In laparoscopic chromoperturbation, with the help of a cannula, I will pass a dye, right? And with the help of a laparoscope, with my own eyes, I will see whether the dye is coming out or not. And simultaneously, I can also see the exterior of the tube. So the gold standard test for tubal infertility is laparoscopic chromoperturbation, right? Now, if the tubes are blocked, in that case, the only management which you have is IVF, in vitro fertilization, right? Now, the fourth cause of female infertility could be a cervical cause, and this is also called as an immunological cause. So many times it happens that in females in the cervix, it's not many times, but yes, sometimes it is seen that in the cervix of the female, anti-sperm antibodies are present. So when a sperm will come inside the cervix, it will get killed. So if this is the case, in that case, what I should do, I should try to avoid this region and this region. So how can I avoid this region? I can avoid this region by putting a cannula, and with the help of this cannula, if I put the sperms directly into the uterus, this is called as intrauterine insemination. So the management of, if there is anti-sperm antibodies present in the cervix, the management is IUI, intrauterine insemination. So if someone asks you what is the management of immunological cause of infertility, it is IUI. Management of unexplained infertility is clomiphene citrate, that you give clomiphene citrate. Again, you will give clomiphene citrate from day 2 to day 6. Then on day 10, you are going to do a follicular monitoring and see how the follicles are growing. When the follicle becomes 18 to 20 millimeter in size, you will give injection HCG, right? And after giving injection HCG, after 32 to 36 hours, instead of telling the female to have intercourse normally, you will do an IUI. So management of unexplained infertility is clomiphene citrate plus IUI, that is intrauterine insemination. So if you remember this much on infertility, that's okay. Now let's talk about infections. Now in infections, very important is PID. A very important question which they ask on PID is that suppose you get a patient of PID, then what kit are you going to use for a patient of PID, and what are the drugs which will be contained in that kit? Another very important question is, all of you know that PID is sexually transmitted, and the most common route of spread of PID is ascending infection along with the sperms. So for the partner, which kit are you going to use? Remember, in a patient of PID, we are going to use kit number 6, which is yellow kit. And this yellow kit has got 3 drugs. Number 1, it has got tablet cefixime, right? Number 2, it has tablet metronidazole. And number 3, it has tablet doxy. Tablet cefixime is going to act against Neisseria gonorrhea. Tablet metronidazole will be effective against anaerobes, and tablet doxy will be effective against chlamydia infection, right? Tablet cefixime 400 mg, 1 tablet is present. Tablet metronidazole 400 mg BD for 14 days. That is the number of tablets which are going to be present. And tablet doxy is given 100 mg BD for 14 days. So these many number of tablets are going to be present in kit number 6, which is for PID, and that's a yellow kit. Now, in order to manage the partner, you have to give kit number 1, which is a gray kit, which will have tablet azithromycin. Tablet azithromycin, that's the drug of choice for chlamydia, and it will have 1 gram tablet of tablet azithromycin. And number 2, it will have tablet cefixime 400 mg, 1 tablet, which is the drug of choice for gonorrhea. Right? So PID, if they ask you what is the most common route of spread of PID, you are going to say it's ascending infection along with the sperms. But there is one PID which is not sexually transmitted, and that PID is genital TB. So let's talk about genital TB. Now, genital TB, the most common primary site in genital TB is lungs, followed by lymph nodes, and from lungs the infection comes to the female genital tract by hematogenous route. In other words, the only PID which is not transmitted sexually is genital TB. What is the most common route of spread of genital TB? It is hematogenous route. If they ask you which is the most common PID in a virgin female, again the answer will be genital TB. Now, in the female genital tract, the most common site affected is the fallopian tube, and in the fallopian tube, if you remember, I told you the most common site is the isthmus, right? Then after fallopian tubes, the second most common site is uterus. Then it's the ovary, cervix, and the least common site is vulva or vagina. Now, in the uterus, that is the endometrial TB, infection will come from the fallopian tube. So, if your question is saying what is the most common route of spread of genital TB, your answer will be hematogenous route. But if question says what is the most common route of spread of endometrial TB, then your answer will be direct spread, because it is coming from the fallopian tube, right? Now, in the tubes, this genital TB can manifest in the form of a tubo-ovarian mass, and in case of genital TB, the tubes get blocked, and because the tubes get blocked, the most common symptom of genital TB is infertility, right? Now, this is what you have to know about the tubes, that when genital TB occurs in the fallopian tube. Now, when genital TB occurs in the uterus, then I told you the most common question which they ask you is what is the most common route of spread of endometrial TB? You are going to say the most common route of spread of endometrial TB is direct spread. Now, in the uterus, genital TB can manifest in one of the two forms. Number 1, it can manifest in the form of Asherman syndrome. Everything what I wanted you to know on Asherman syndrome, we've already covered. Number 2, it can manifest in the form of pus inside the uterus, which is called as pyometra, right? Now, on pyometra, the questions which they ask you is, what is the most common cause of pyometra? The most common cause of pyometra is senile endometritis or senile atrophy, right? You are not going to say it is genital TB. If they ask you what is the most common cause of hematometra, you know it is imperforate hymen, right? Now, in a patient of genital TB, HSG is contraindicated, although whenever there is a tubal block, I told you investigation of choice is HSG, but if the tubal blockage is due to genital TB, then you don't have to do HSG. It is contraindicated. Why? Because when you pass a dye in genital TB, and if the dye comes out from the fallopian tube, it is going to lead to the spread of genital TB. That is why in genital TB, HSG is contraindicated. But for example, suppose I did not know my patient has genital TB and I do an HSG. In that case, I am going to get certain characteristic appearances. And these characteristic appearances are: number one, I can get a lead pipe-like appearance. Number two, I can get a tobacco pouch-like appearance. Number three, beaded appearance. Number four, golf stick-like appearance. And number five, bilateral cornual block. Now, as far as bilateral cornual block is concerned, I told you that the most common cause of bilateral cornual block is physiological spasm, but most common pathological cause is genital TB. Now, how do you manage genital TB? Management of genital TB is ATT, which you will have to give for 6 months. But if they ask you, how do you manage infertility in a patient of genital TB? Now, infertility in genital TB is happening because of tubal blockage, and all of us know that the management of tubal blockage is IVF. So, management of infertility in a patient of genital TB is IVF, in vitro fertilization. Right? Now, last point which you have to remember in genital TB is that in case of genital TB, you get Asherman syndrome. And if you do an HSG in Asherman syndrome, you get a cobweb-like appearance. So, on HSG in Asherman syndrome, you get a cobweb-like appearance. Right? This is what you had to know about genital TB. Now let's talk about vaginitis. In vaginitis, the first thing we are going to talk about is bacterial vaginosis. As the name suggests, you can see it is vaginosis. It is not vaginitis. In other words, there is no inflammation. So if there is no inflammation, there will be no itching, and in other words, there will be no pruritus. What happens in bacterial vaginosis? There is alteration of vaginal flora. The Doddeline bacilli of the vagina are replaced by Gardnerella. That is why earlier it was also called Gardnerella vaginitis. In a patient of bacterial vaginosis, patient will not have any itching, but patient will complain of foul-smelling, dirty white discharge. The pH of the discharge will be more than 4.5, and Amsel's criteria will be present. You don't need to know the details of Amsel criteria. Just remember, Amsel's criteria will be present. When you will do a saline microscopy, you will see clue cells. Now, what are clue cells? Clue cells are vaginal epithelial cells. So, this is a clue cell to which the bacteria are adhered. Right? So, vaginal epithelial cells to which the bacteria are adhered, they are called as clue cells. Whiff test will be positive in bacterial vaginosis. What is whiff test? When you add 10% potassium hydroxide to the discharge, you get a fishy odor, right? Or an amine-like odor. Bacterial vaginosis is not sexually transmitted. So these are important points which you had to remember about bacterial vaginosis. Now let's talk about Trichomonas vaginitis. Trichomonas vaginitis is sexually transmitted. The causative agent for Trichomonas vaginitis is a flagellated protozoa, that is Trichomonas vaginalis. In Trichomonas vaginitis, patient will complain of greenish yellow discharge, and the pH of the discharge will be more than 4.5. You will get a characteristic appearance of the vagina. Vagina will appear red in color, and that is called as strawberry vagina. And the investigation of choice in Trichomonas vaginitis is saline microscopy. When you will do a saline microscopy, you will see something moving, and that something moving will be the Trichomonas vaginalis, right? Then let's talk about candidiasis. Candidiasis is the most common vaginitis in pregnancy. It is the most common vaginitis in diabetic patients, in females who are using OCPs, in females who are using steroids, and in females who use antibiotics for a very long time. Candidiasis is caused by a fungus, that is Candida albicans. Patient complains of curd-like cottage or a cottage cheese-like discharge. Either there will be a curd-like discharge or cottage cheese-like discharge. And patient will complain of intense itching. Candidiasis may be sexually transmitted, right? The drug of choice for bacterial vaginosis and for trichomonas is metronidazole. The drug of choice for candidiasis is fluconazole. And for vaginal discharge, the kit which is available is kit number 2, which has got fluconazole, and instead of metronidazole, it has secnidazole, right? Now, because bacterial vaginosis is not sexually transmitted, so in bacterial vaginosis, treatment of the male partner is not necessary, is not needed. It's not necessary, nor it's not needed at all. In trichomonas, because trichomonas is sexually transmitted, so the treatment of male partner is absolutely essential. Candidiasis may be sexually transmitted, so if the male partner shows signs and symptoms of discharge, then in that case, you are going to treat the male partner in candidiasis only if symptoms are present, right? So this is what you needed to know about infections, that is PID, and about vaginitis. Now, at least 2 to 3 questions on contraception should be expected in any exam. And contraception I have dealt in detail in a previous lecture which I had given in Marrow, which is again shared on YouTube and is there to be watched by any one of you. The link for that video I am going to share in the comment box. Please do not forget to watch the contraception lecture from there and to note all the points which I have told there, right? And in continuation with the revision series which we have started for FMGE, the Obs and Gynae revision for FMGE students, today I'm going to talk about the gynae cancers, the cancer cervix, cancer endometrium, and cancer ovary. And I am not going to tell you each cancer separately. I have devised a very useful method for revising cancers quickly, and that is we are going to talk about all these 3 cancers together in a tabulated format. Right? Now, if the PG entrance students, you are watching this video, this table is very useful for you also. The only difference will come in the management part. The management part for PG entrance or for AIMS is a little more detailed in comparison to what is needed for the FMGE students, right? So I want all of you to put your notebooks in a landscape manner and make a table. Now, the first column is going to read headings, second column, cancer endometrium, third column, cancer cervix, fourth column, cancer ovary, right? Now, the first heading is which one of them is the most common genital tract cancer in India. So, the cancer cervix is the most common genital tract cancer in India. Now, let's talk about the pre-malignant conditions. The pre-malignant condition for endometrial cancer is endometrial hyperplasia. Endometrial hyperplasia is of 4 varieties: simple hyperplasia without atypical cells, complex hyperplasia without atypical cells, simple hyperplasia with atypical cells, and complex hyperplasia with atypical cells. Now, what they ask you is what are the chances of turning into malignancy in each of these conditions. So you are going to write them like this in this order, and you're going to remember this as 1, 3, 8, and 30, right? So common sense tells me least chances of malignancy will be seen with simple hyperplasia without atypical cells. Simple hyperplasia without atypical cells is also called as cystic glandular hyperplasia. So in your options, either you can get simple hyperplasia without atypical cells or you can get cystic glandular hyperplasia. Maximum chances will be with complex hyperplasia with atypical cells, right? So this was about the pre-malignant condition, the name of the pre-malignant condition for endometrial cancer. Now, the name of the pre-malignant condition for cancer cervix is CIN, cervical intraepithelial neoplasia, which can be CIN1, CIN2, CIN3, and cancer in situ. Now, as per the Bethesda classification, CIN1 comes under LSIL, and I'm sure by this time all of you know what LSL stands for. LSIL stands for low squamous intraepithelial lesions, and CIN2, 3, and cancer in situ will come under HSIL, high squamous intraepithelial lesion. Now, in CIN, you have to remember that the age group for CIN is 20 to 30 years, and for cancer in situ is 31 to 35 years, right? Now, In case of cancer ovary, the pre-malignant conditions as such, we have, the question comes for adnexal mass. Now, this adnexal mass could be a benign mass or it can be a borderline tumor. The most common benign tumor in cancer ovary is a dermoid cyst, which is called as a mature teratoma, right? That's the most common benign tumor of the ovary. Then there can be borderline tumors. Borderline tumors are also called as low malignant potential tumors. The age group for borderline tumors is earlier than the age group for malignant tumors, and they are seen between 30 to 50 years of age. And how do we say it's a borderline tumor and it's not a malignant tumor, or it's a low malignant potential tumor and not a fully malignant potential tumor? Because stromal invasion will be absent on histopathological examination, right? So this was about their pre-malignant condition. We are continuing with the pre-malignant conditions only just now. The next heading is, what are the risk factors for the pre-malignant condition? So the risk factor for pre-malignant condition of endometrial cancer, that is endometrial hyperplasia, is excessive estrogen. So endometrial hyperplasia, it occurs because of excessive estrogen, and because of excessive estrogen, there will be excessive proliferation of the endometrium, and patient is going to come to you with complaint of excessive bleeding. As far as CIN is concerned, the risk factors are human papilloma virus, that's the most important risk factor, followed by multiple partners, low socioeconomic status, multiparity, intercourse at less than 18 years of age, smoking, and immunocompromised states like HIV. And the risk factors for ovarian tumors, the pre-malignant condition for ovarian tumors are excessive estrogen and excessive ovulation, right? Then, how do you make a diagnosis of the pre-malignant condition? Now, in case of endometrial hyperplasia, patient is going to come to you with excessive bleeding. And whenever a patient comes to you with excessive bleeding, the first investigation which you should do always is TVS. And on TVS, I'm going to measure the endometrial thickness. If endometrial thickness in premenopausal females is more than equal to 12 millimeters, or in a postmenopausal female it is more than equal to 4 millimeters, then it rings a bell that it means the endometrium is thick, which means there will be excessive estrogen, and it could be that she has endometrial hyperplasia. So in that case, I'm going to do the investigation of choice, which is endometrial aspiration biopsy. Endometrial aspiration biopsy, it is an OPD procedure. It's an OPD procedure which you are going to do with the help of two instruments, either of these. You can do it with the help of a Vabra aspirator, you can do it with the help of a Carman's cannula, or you can also do it with the help of a Pipli. Generally, we use a Pipli or a Vabra aspirator. Only if these two things are not available, then we go for a Carman's cannula, otherwise no. Right? In case of CIN, when we talk about diagnosis, so I'm coming to CIN diagnosis, the screening method is a pap smear. Now, because the age group for CIN was 20 to 30 years, I am going to begin my screening from 21 years of age, irrespective of the irrespective of whether the female started her intercourse before that, right? Obviously, if female is starting her sexual life after 21 years, I'm going to delay it. But if the female started her sexual life before 21 years, then also the age group for starting screening for cancer cervix is 21 years. So if your question says that there is a female who began her sexual life at 18 years, when should the first pap smear be done? You are going to start doing it at 21 years, right? Now, from 21 to 29 years, every 3 years, I'm going to do a pap smear. Then, from 30 years onwards, I'm going to do a pap smear plus HPV DNA testing. And this I'm going to do every 5 years till the female reaches 65 years of age. right? So till 29 years, only pap smear every 3 years. From 30 years onwards, you will do pap smear plus HPV DNA testing every 5 years till 65 years of age. Now, the instrument which is used for doing pap smear is the Ayers spatula and endocervical brush. But as I told you, pap smear is just a screening method. What will be the diagnostic method if pap smear report comes out to be positive? Now, when a pap smear report comes, then the report can come as ASCUS. What is ASCUS? Atypical squamous cells of unknown significance, right? Atypical, A for atypical, S for squamous, C for cells, U for unknown, S for significance. So the histopathologist can say that, yes, I am getting a few atypical cells, but I don't know their significance. In that case, if the female's age is more than equal to 25 years, normally HPV DNA testing starts from 30 years. But if the report comes as ASCUS, then you can do HPV DNA testing from 25 years onwards. So if your report comes as ASCUS and the female's age is more than 25 years, go for HPV DNA testing. And then if HPV DNA testing comes out to be positive, in that case, you are going to go for colposcopy, right? Now, if report comes as LSIL or HSIL, that is low squamous intraepithelial lesion or high squamous intraepithelial lesion, then it means that there are chances of malignancy. And for malignancy, always the diagnostic test becomes biopsy. So what I'm going to do is I'm going to call the female, I'm going to look at her cervix. If I can see a lesion present, then I know this is the place exactly from which the biopsy should be taken. And in that case, I'm going to go for a punch biopsy. But if lesion is not visible, in that case, I'm going to go for colposcopy, right? Now, here I want you to write just one thing, that is case 1. Just write a case 1 and later on I'll tell you what that case is. We'll deal with all the cases separately. So just write in this table case 1 here, right? So we will be doing a case related to this just now, right? Now, this is how you diagnose CIN. Now, let's talk about the diagnosis of ovarian tumors, the benign tumors and the borderline tumors. Now, for ovarian tumors, whenever you get an adnexal mass, you have to go for CA 125 levels. But in females of reproductive age, there is no value of CA 125. Right, the significance of CA 125 is very less because CA 125 levels in a reproductive age female are raised in many other conditions apart from cancer ovary. But if this is a postmenopausal female, then yes, you have to go for CA 125 levels. And if CA 125 levels are more than equal to 35 international units, then it means that it is going towards cancer and you are going to go for surgery. You are going to remove that mass, right? Apart from CA 125 levels, you are going to get an ultrasound done, which is the investigation of choice. And ultrasound can help you to distinguish between a benign and a malignant mass. How can you know the difference between benign and malignant? Usually benign masses are unilateral, whereas malignant masses are bilateral. Benign masses, generally they have a cystic consistency, whereas malignant masses will have a variable consistency. They will have some solid component as well. In benign masses, you will get a thin septa less than 3 millimeters thick, whereas in malignant masses, you will get a thick septa more than equal to 3 millimeters, right? If on ultrasound you are getting ascites, you are getting enlarged lymph nodes, or you are getting matted bowel loops, then that indicates that it is a malignant mass rather than a benign mass. So in case of adnexal masses, the investigation of choice to distinguish between benign and malignant will be ultrasound, right? Now, how do you manage the pre-malignant conditions? Now, as I told you, the pre-malignant condition for endometrial cancer was endometrial hyperplasia, and you can get either hyperplasia without atypical cells, or you can get, so there can be cases where you are getting without atypical cells and there can be cases where you are getting with atypical cells. From here, it's very clear that without atypical cells, the chances of malignancy in simple hyperplasia are 1% and in complex hyperplasia are 3%, which are very, very less. So in management, when the report comes, I'm going to look at the report and see whether you are getting endometrial hyperplasia without atypical cells or you are getting with atypical cells. If it is without atypical cells, because I know that the excessive hormone is estrogen, so in order to counteract its effect, I'm going to give progesterone. So if your question says that there is simple hyperplasia or complex hyperplasia without atypical cells, what is the management? The management will be you have to give progesterone. But if your question says that there is simple hyperplasia or complex hyperplasia with atypical cells, in that case, the chances of malignancy are very high. In case of simple hyperplasia with atypical cells, the chances of malignancy are 8%, whereas in complex hyperplasia with atypical cells, the chances of malignancy are 30%. So in that case, I am going to do hysterectomy. Right? So in endometrial hyperplasia, management depends upon whether it is without atypical cells or whether it is with atypical cells. Right? Now let's see how you are going to manage CIN. See, management of CIN should be done only when CIN is confirmed. That means after colposcopy or punch biopsy has been done. Just based on pap smear report, you never go for managing CIN. And that is a catch. Many questions you will get where they will say a pap smear report shows CIN3. What is the next step? So if the pap smear report is showing any CIN, the next step is to confirm it with the help of colposcopy. But once the report from colposcopy or from punch biopsy says that yes, CIN is confirmed, then you have to manage it. In case of CIN1, you don't have to do anything. You just have to follow it up for 2 years because most of the cases of CIN1 will regress after 2 years. But if CIN1 persists even after 2 years, then you have to go for cryosurgery. Right? Now, if it is a case of CIN2 or CIN3, the only management, no matter what is the age of the patient, no matter what is the parity of the patient, even if they are saying you she's a 45 years old female, even if she's saying you she has 2 children, 3 children, 4 children, irrespective of the age, irrespective of the parity, management is LEEP or LLETZ. What does LEEP stand for? Loop electroexcisional procedure. And what does LLETZ stands for? Large loop excision of transformation zone. So I am going to take an instrument. It's a wired instrument like this. It has a very thin wire and I'm going to pass a current around the transformation zone, and within 5 to 10 minutes, your patient will be cured. This procedure is an OPD procedure. No anesthesia is needed. And that is why the management for CIN2 and CIN3 these days is LEEP, loop electroexcisional procedure, or LLETZ, large loop excision of the transformation zone. Write it in red that hysterectomy is not done in CIN. So you are not going to mark the answer as hysterectomy in any case. CIN means you have to go for LEEP or LLETZ, CIN2 and CIN3. CIN1 means you are going to follow it up for 2 years. If it persists, then you are going to go for cryosurgery. Now, in case of ovarian tumors, just write in the table case 2 and case 3 and leave it. Now, this is what I wanted you to know about the pre-malignant conditions. Right now, let us see what are these case 1, case 2 and case 3 I'm talking about. End the table here because the pre-malignant conditions ends here. Write case 1, case 2 and case 3. Now, what is case 1? Case 1 is, suppose your question says that there is a female with pap smear report positive. So pap smear is showing that yes, CIN is present, right? But colposcopy report comes out to be negative. Then what is the next step? So one thing very important which you have to remember over here is that colposcope is a magnifying instrument which can visualize the exocervix very well, which can visualize the transformation zone also. But it cannot visualize the endocervix, especially the upper part of endocervix. So if your pap smear report is saying that it is positive, CIN is present, but colposcopy is saying negative, before you say that to the patient that there is nothing there, you should always remember that colposcope cannot visualize endocervix. So in that case, it could be that our area of concern, the pre-malignant condition or the cancerous condition, is located in the endocervix. So in that case, in earlier days, the next step was conization or cone biopsy, right? In cone biopsy, we take a cone-shaped area of the cervix. This cone should include exocervix. It should include a part of transformation zone, and it should include endocervix. So you are going to make a cone in such a manner that all these three areas are included, and you are going to send it for biopsy. This is called as cone biopsy. Obviously, if you are cutting an area of cervix, it has to be done under general anesthesia, and it is an OT procedure. Whereas colposcopy was OPD procedure and no anesthesia was required, right? So if pap smear report comes out to be positive, but your colposcopy report is negative, in that case, in earlier days, we used to do a cone biopsy or conization. These days, we go for endocervical curettage. So look in the options. If endocervical curettage is present, that's a very good answer to mark. But if endocervical curettage is not present, then definitely conization or cone biopsy would be present, right? This was case 1, which I was talking about. Now let's talk about case 2. Case 2 is, suppose your question says, and this is related to the ovarian mass, right? So case 2, you had written under the column of ovarian cancers. The pre-malignant condition of ovarian. Case 2 and case 3 was written there. Now, case 2 is, suppose you are getting a benign adnexal mass in reproductive age. So, if a question comes like this, that there is a female who goes for an ultrasound, and on ultrasound, an adnexal mass is present. What is the next step? Now, whenever a question comes like this, you should look at the size of the mass. If the size of the mass is between 3 to 5 centimeters, you don't have to worry, you just have to wait and watch. If the size of the mass is between 5 to 7 centimeters, in that case, you have to follow it up with ultrasound. And if size of the mass is more than equal to 7 centimeters, then the chances of the mass getting converted into malignancy are high. In that case, you have to remove it. So this is how you manage an adnexal mass in a reproductive age female, right? Similarly, if a question comes that there is an adnexal mass which is present in a post-menopausal female, in a reproductive age female, ultrasound is going to decide how you are going to manage. In a post-menopausal female, you are going to measure her CA-125 levels, and if CA-125 levels are more than equal to 35 international units, then you are going to remove it. Or if size of the mass is more than equal to 7 centimeters, then you are going to remove it, right? So in postmenopausal females, check her CA-125 levels. If they are more than 35 international units, remove the mass. Or do an ultrasound. If size is more than equal to 7 centimeters, remove the mass, right? So this is what I wanted you to know about the pre-malignant conditions of endometrium, of cervix, and of the ovary. Now let's talk about the cancer endometrium, cancer cervix, and cancer ovary. So we have talked about the pre-malignant conditions. Now we are going to talk about the cancer endometrium, cancer cervix, and cancer ovary in a similar manner. This is going to help you immensely in your revision. Your gynae cancers will be, revised so quickly with the help of this table. So continue writing. So you will have 4 columns. On the left-hand side column, there will be heading. Then there will be cancer endometrium, cancer cervix, and cancer ovary. So first thing about all of them, the first heading which we are going to discuss is the age. So the most common age for cancer endometrium is 5th to 7th decade. Cancer cervix, it has got two peaks. One peak is between 35 to 39 years and the other one is 55 to 60 years. Now, as far as the cancer ovary is concerned, the most common variety of cancer ovary is epithelial cell tumors, and the most common age group for epithelial cell tumors is 60 to 70 years. But the most common age group for germ cell tumors is 10 to 20 years. So much so that if you are getting an ovarian cancer in this age group, the chances of germ cell tumor being are 70%. So 70% tumors between 10 to 20 years of age are germ cell tumors. Sex cord tumors, they are found in all age group, but they are more common in perimenopausal age group. But they can be seen in any age group, right? Then, parity. In which parity are these cancers common? So remember, cancer endometrium, if you remember endometrial hyperplasia, I told you that endometrial hyperplasia is because of excessive estrogen. Cancer endometrium is also because of excessive estrogen, and cancer ovary is also because of excessive estrogen. A few common things which you have to remember about all hyperestrogenic conditions, in gynae, whether it is fibroid, whether it is endometriosis, whether it is cancer endometrium, or whether it is cancer ovary. All these hyperestrogenic conditions, they are more common in obese females. Why more common in obese females? Because in adipose tissue, the androgens get converted into estrogen. So more is the adipose tissue, more are the chances of androgen getting converted into estrogen, right? They are more common in nulliparous females. They are more common if there is early menarche, because then the female will be exposed to estrogen more, and they are more common in late menopause, right? So all these hyperestrogenic conditions, they have these some common risk factors, and some common protective factors in all these hyperestrogenic conditions are: if obesity is a risk factor, then exercise becomes a protective factor. If nulliparity is a risk factor, then multiparity becomes a protective factor. In other words, pregnancy becomes a protective factor. And one very important protective factor in all these conditions is smoking, because see, when androgens are converted into estrogen in adipose tissue, then the enzyme which is needed is aromatase enzyme. And what smoking does is, smoking inhibits this enzyme, right? So it prevents the conversion of androgens into estrogens, and that is why smoking is protective in fibroid, in endometriosis, in cancer endometrium, and cancer ovary, right? So with this background, come back here again. So if I ask you cancer endometrium, it will be more common in nulliparous or multiparous. You will say it's more common in nulliparous because it is related to excessive estrogen. On the other hand, cancer cervix is more common in multiparous females. And similarly, cancer ovary, like cancer endometrium, is more common in nulliparous female because cancer ovary is also due to excessive estrogen. Right? Now, just now I said that obesity is a risk factor for all these excessive estrogen conditions. So this means the general appearance of a female who has cancer endometrium will be, she will be obese. Right? Normally, if a female has cancer, we expect them to look very thin, cachexic, malnourished, right? But in case of cancer endometrium, the female will be obese. In case of cancer cervix, she will be thin, cachexic, and there will be a foul smell coming from her. In cancer ovary, the female again will be obese because cancer ovary is also an excessive estrogen condition, right? Then cancer endometrium and cancer ovary, they are generally more common in high socioeconomic status, and cancer cervix is more common in low socioeconomic status. Risk factors. Now, risk factors for cancer endometrium, you can remember by a mnemonic, that is, family has old aunties, where family stands for family history. H has the H of has stands for hypertension. O for obesity. L for late menopause, early menarche. D for diabetes. A for atypical endometrial hyperplasia. U for unopposed estrogen. This unopposed estrogen can be in the form of PCOS, it can be in the form of hormone replacement therapy, it can be in the form of estrogen secreting ovarian tumors. N for nulliparity, and T for tamoxifen treatment. Now this was an AIMS question. That tamoxifen treatment can lead to which cancer? So it can lead to endometrial cancer. I for history of infertility, and S for senile endometritis. Right? Why infertility? Because nulliparity is a risk factor. So history of infertility is also a risk factor. Right? Now, in these, if you look at 3 of them, I have made a circle. Hypertension, obesity, and diabetes. So if a female is hypertensive, obese, and diabetic, she has increased chances of having endometrial cancer, and this is called as the corpus cancer syndrome. Right? So these are the risk factors for endometrial cancer. Right? Coming to cancer cervix, the risk factors for cancer cervix are same like CIN. And again, the most important risk factor will be HPV, human papilloma virus. A few to write a few details about HPV. In HPV, there is low risk subtype and high risk subtype. The low risk subtypes are HPV 6 and 11. High risk subtypes are 16, 18, 31, 33, 35, 39, 45, 52, right? In which 16 and 18 are very important and you have to remember them. Now, if they ask you which is the most common HPV associated with cancer cervix, or if they ask you which is the most common HPV associated with squamous cell carcinoma of the cervix, in both these cases, your answer will be HPV 16. Right? So the most common HPV associated with cancer cervix or the most common HPV associated with squamous cell carcinoma of the cervix, answer is HPV 16. But if they ask you which is the most specific for cancer cervix, which HPV, or which HPV is associated most commonly with adenocarcinoma of the cervix, in that case, your answer will be HPV 18, right? So for squamous cell carcinoma, it was 16. For adenocarcinoma, it is 18. Most common is 16. Most specific is 18. Now, if they ask you which HPV is associated with genital warts, so it is HPV 6 and 11, which is associated with genital warts, right? So these were the the rest of the risk factors like immunocompromised states, then your the low socioeconomic status, early age of intercourse, all are same like CIN, right? Now, let's talk about the risk factors for cancer ovary. Now, there are 2 risk factors for cancer ovary. Number 1, if there is excessive estrogen, that is a risk factor. And number 2, there is a theory which says that more is the ovulation, more are chances of ovarian cancer, right? Now, risk factors related to excessive estrogen, just now I told you, if female is obese, then that's a risk factor, nulliparity, early menarche, and late menopause. Risk factor related to increased ovulation is use of ovulation-inducing drugs. Apart from that, ovarian cancer is more common if the gonads are dysgenetic, right? So in dysgenetic gonads also, you will get ovarian cancer. So these were the risk factors for cancer endometrium, cancer cervix, and cancer ovary. Now, let's look at familial inheritance. In familial inheritance, in cancer endometrium, you have to remember that familial inheritance is seen. So, endometrial cancer is more common in patients of HNPCC. What is HNPCC? Hereditary non-polyposis colorectal cancer. Hereditary non-polyposis colorectal cancer or link 2 syndrome. So yes, familial inheritance is present in endometrial cancer. It is seen in 5% cases and it is seen in patients of link 2 syndrome. See, normally in endometrial cancer, we do not do any screening. But in patients of link 2 syndrome, you should do screening, and screening should begin at 35 years of age. Right? And how are you going to do the screening? You are going to do screening by doing a TVS and endometrial biopsy every 6 to 12 months beginning from 35 years of age. So normally endometrial cancer, no screening needed. Screening is needed only in patients of link 2 syndrome. Now, if they ask you what is the best method of screening in patients of link 2 syndrome, the best method is fractional curettage. That's the best method. But that's the best method of screening. In MCI, the question was asked, which is the best method to prevent cancer in endometrial cancer in patients of link 2 syndrome? So what is the best method to prevent endometrial cancer? It is not screening. Best method to prevent endometrial cancer is you do a TAH plus BSO. What is a TAH plus BSO? Total abdominal hysterectomy plus bilateral salpingo-oophorectomy. So you are doing a TAH plus a BSO. That means you are removing the uterus, the cervix, both the tubes and the ovaries. And this should be done after they have produced, that after they have completed their family. But in any case, it has to be done before 40 years, right? So this is the best method to prevent endometrial cancer in link 2 syndrome. And as I told you, yes, familial inheritance is seen in endometrial cancer. But as far as the cancer cervix is concerned, in cancer cervix, there is no familial inheritance. Familial inheritance is not seen in cancer cervix. Okay, now let's see what about cancer ovary. In cancer ovary, familial inheritance is seen, and it is seen most commonly if there is a mutation in BRCA1 gene, BRCA2 gene, and in patients of hereditary non-polyposis colon cancer, right? So in BRCA1, BRCA2 and hereditary non-polyposis colon cancer. So here you could have asked me that, ma'am, if the female has hereditary non-polyposis colon cancer, there is a risk of endometrial cancer. I agree, we are going to remove the uterus, we are going to do hysterectomy. Then why bilateral salpingo-oophorectomy? Why to remove the ovaries? This is the reason to remove the ovaries, because these patients also have increased risk of ovarian cancer. Always remember, hereditary ovarian cancers, they are seen 10 years younger to the normal age group in which ovarian cancer happens, right? And again, if they ask you what is the best method to prevent ovarian cancer in any of these patients, if a patient is BRCA1, BRCA2 or HNPCC patient, you are going to say best method to prevent cancer is do a TAH plus BSO, that is total abdominal hysterectomy plus bilateral salpingo-oophorectomy between 35 to 40 years of age. And in no case you have to, in all cases, you have to do it at less than 40 years of age. So the best time to do is between 35 to 40, right? So this was about familial inheritance. Now, let's talk about the protective factors in all these cancers. As I told you, endometrial cancer is related to excessive estrogen. And just now only we had discussed that in all hyperestrogenic conditions, the protective factors are exercise, multiparity, pregnancy, and smoking, right? So in endometrial cancer also, these will be the protective factors. In case of cancer cervix, the protective factor is the HPV vaccines. So we have vaccines which are available against HPV. There are 3 kinds of vaccines which are available. So we have a bivalent vaccine, a quadrivalent vaccine, and the new one is a nonavalent vaccine. Now, bivalent vaccine is Cervirax, and as the name suggests, it is going to be active only against 2 strains of HPV, and they are HPV 16 and 18. Quadrivalent vaccine is Gardasil, and because it is quadrivalent, it is acting against 4 strains of HPV, HPV 16, 18, 6, and 11. Whereas the nonavalent vaccine Gardasil 9 is active against the 9 strains of HPV, 9 subtypes of HPV, 16, 18, 6 and 11 was already there. Apart from that, 31, 33, 45, 52 and 58, right? So HPV nonavalent vaccine, you will have to remember that it is active against which strains. So remember 16, 18, 6 and 11 was there for Gardasil also. Apart from that, 31, 33, 45, 52 and 58. Right? Now, because Cervirax is active only against HPV 16 and 18, so it prevents against cancer cervix. Because Gardasil is acting against 16, 18 and 6 and 11, so it is going to be good, or it will be protective against cancer cervix as well as genital warts. Whereas Gardasil 9 will be protective not only against cancer cervix and genital warts, but also against vulva and vaginal cancer. Right? Now, all these 3 vaccines, they can be given to both boys and to girls. In girls, obviously, they will prevent cancer cervix. In boys, they prevent cancer anus and penis cancer. Right? Now, all these vaccines are contraindicated in pregnancy. The age in which you can give these vaccines is between 9 to 26 years, and ideal age being 11 to 12 years. Right? Now, if the age of the patient is less than 14 years, you should give 2 doses. And if the age of the child is more than equal to 15 years, you should give 3 doses. Right? So these are all questions which you have to know on HPV vaccines. In other words, the protective factor for cancer cervix. Now let's talk about the protective factor for cancer ovary. Now, if you remember, ovarian cancer was because of excessive estrogen. So all those things were what were protective against excessive estrogen will be protective in ovarian cancer. Right? So exercise, multiparity, pregnancy and smoking. They are all protective in ovarian cancer also, like they were protective in endometrial cancer. Now, apart from that, in ovarian cancer, one more risk factor was, and that was excessive ovulation. So all those factors which decrease ovulation will also be protective in ovarian cancer, and that is breastfeeding, hysterectomy, tubal ligation and anovulation. So these are the protective factors: breastfeeding, hysterectomy, tubal ligation and anovulation, apart from the 4 common ones which we have discussed. So this is the protective factor in ovarian cancer. I hope all of you are noting these points. These are very, very important points, right? Now, let's talk about the most common variety of the cancer. See, uterus is lined by the columnar epithelium. Because uterus is lined by columnar epithelium, so the most common variety of endometrial cancer which you are going to get will be adenocarcinoma, or the endometrioid variety. That is the most common variety. If they ask you which is the most malignant variety, then the most malignant variety is the clear cell carcinoma or papillary serous tumor, right? So this is about endometrial cancer, in which the most common is adenocarcinoma, but most malignant is clear cell carcinoma or papillary serous tumor. Now, if we talk about the cervix, in yesterday only I had discussed with you that in cancer cervix, the most common variety is squamous cell carcinoma, which is a large cell keratinizing variety. And the most common site for squamous cell carcinoma will be the transformation zone or the squamocolumnar junction. I also discussed with you yesterday that endocervix is lined by columnar epithelium. That is why adenocarcinoma can also be seen in the cervix. And the most common site for adenocarcinoma will be endocervix. All these things we had discussed in anatomy revision yesterday, right? If they ask you overall which is the most common site, then yes, overall the most common site is the transformation zone or squamocolumnar junction, because overall the most common variety is squamous cell carcinoma, right? Now, let's talk about ovarian cancers. Classification of ovarian cancer is very, very important. The most common group of ovarian cancer, or the most common variety of ovarian cancer, is epithelial cell tumor, which is seen in 90% cases. The most common benign epithelial cell tumor is serous cyst adenoma, and the most common malignant epithelial cell tumor is serous cyst adenocarcinoma. So here I am talking about the most common benign epithelial tumor, which is serous cyst adenoma, and most common malignant epithelial cell tumor, that is serous cyst adenocarcinoma. Read your question very carefully. If they are asking about epithelial cell tumor, then this is the answer. But if your question is overall, which is the most common benign tumor of the ovary. So as discussed previously, the most common benign tumor of the ovary is dermoid cyst, and the most common malignant ovarian tumor is serous cyst adenocarcinoma. So in epithelial cell tumors, we have number 1 variety, that is serous variety. Number 2 variety is mucinous variety. Then there is a clear cell tumor, endometrial tumor, and Brenner tumor. So these are the varieties of epithelial cell tumor. Then the second variety of cells can be germ cell tumors. And as I told you, germ cell tumors are more common in young females, 10 to 20 years of age. Most common benign germ cell tumor is dermoid cyst, and the most common malignant germ cell tumor is immature teratoma. Dermoid cyst is a mature teratoma which is benign. Most common malignant germ cell tumor is immature teratoma followed by dysgerminoma. Earlier we used to say it is dysgerminoma, now it has changed to immature teratoma. Now, if they ask you which is the most malignant germ cell tumor or the germ cell tumor which has the worst prognosis, then your answer will be endodermal sinus tumor, which is also called as the yolk sac tumor. So, most common malignant is immature teratoma, but the most malignant is endodermal sinus tumor or yolk sac tumor. That is why I always tell, read your question very, very carefully. The other germ cell tumors are choriocarcinoma and embryonal carcinoma. The third variety of ovarian cancers can be sex cord tumors. In sex cord tumors, we have estrogen secreting tumors, that is the feminizing tumors, or you can have testosterone or androgen secreting tumors, that is masculinizing tumors. In feminizing tumors, there is the granulosa cell tumor, fibroma, and thecoma. Whereas in masculinizing tumor, there is Sertoli cell tumor, Leydig cell tumor, and Hylas cell tumor. Very, very important classification. You have to remember the classification of ovarian cancer, right? Let's talk about the most common symptom. The most common symptom in case of cancer endometrium is irregular bleeding. Please mark that, it's irregular bleeding. Whereas the most common symptom in cancer cervix is again irregular bleeding. So in both cancer endometrium and cancer cervix, the most common symptom is irregular bleeding. But if they ask you what is the most specific symptom in case of cancer endometrium, the most specific symptom will be postmenopausal bleeding, right? Most common for cancer endometrium is irregular bleeding. Most specific is postmenopausal bleeding. Now, about postmenopausal bleeding, a few questions are asked, which are, what is the most common cause of postmenopausal bleeding? PMB. So, the most common cause of PMB is endometrial atrophy. Please do not say that the most common cause is cancer endometrium. It's not cancer endometrium, it's endometrial atrophy. But if the question says that what is the most common cause of PMB in India, then your answer is cancer cervix. The third question which they ask you is, what is the percentage of PMB patients who actually have endometrial cancer? So the percentage of PMB patients who have endometrial cancer are 10%. Now, in case of PMB also, like in normal bleeding where I told you in endometrial hyperplasia, that whenever a patient will come to you with PMB, the first investigation you are going to do is TVS. Now, in a postmenopausal female, if endometrial thickness is more than equal to 4 millimeters, then you are going to go for endometrial aspiration biopsy. So, the first investigation in PMB is TVS, but the investigation of choice in PMB is endometrial aspiration biopsy, right? Now let's talk about cancer cervix. In cancer cervix also, the most common symptom is irregular bleeding, but the most specific symptom is postcoital bleeding, right? Now here, write down case 4 and then we'll discuss this case 4 a little later. So just write case 4 over here and leave it for now, right? Then, what is the most common cause of death in cancer cervix? The most common cause of death in cancer cervix is uremia or renal failure, right? So, that was cancer cervix. Now, let's talk about cancer ovary. In cancer ovary, the most common symptoms which you get are actually vague symptoms in epithelial cell tumor, which is the most common tumor. You will get very vague symptoms. Patient will have nausea, vomiting, abdominal pain, and most of the time the symptoms are going to resemble irritable bowel syndrome symptoms. And that is why ovarian cancer is detected at a very, very late stage, right? In case of mucinous tumors, in epithelial cell tumors, there is a variety mucinous tumor. In mucinous tumor, you get pseudomyxoma peritoni. Very oftenly, this question is asked. Now, what happens in pseudomyxoma peritoni? The entire peritoneum is filled with mucinous material, right? And if they ask you what is the most common cause of pseudomyxoma peritoni, the most common cause of pseudomyxoma peritoni is not a mucinous tumor of the ovary. The most common cause of pseudomyxoma peritoni is appendix cancer, right? But in ovarian cancer, yes, pseudomyxoma peritoni is seen in mucinous tumors. Now, as far as the germ cell tumors are concerned, I told you germ cell tumors, they are seen in young pubertal females, 10 to 20 years. And germ cell tumors, they secrete HCG, right? So that is why in germ cell tumors, the presentation is as precocious puberty. Whereas sex cord tumors, now in sex cord tumors, we are talking about the estrogen secreting tumors. Now, depending upon the age group, as I told you, sex cord tumors, they can be seen in any age, but the most common age group was perimenopausal females. But because sex cord tumors, the granulosa cell tumor, it secretes estrogen. So if estrogen is secreted in a young female, the patient will come to you with as a case of precocious puberty. If she's coming in, if germ cell tumor happens in, not the germ cell tumor, sorry, the granulosa cell tumor or the sex cord tumor which secretes estrogen, if it happens in reproductive age group, then patient is going to come to you with excessive bleeding at irregular intervals, and that is called as menometrorrhagia. And if this granulosa cell tumor or estrogen secreting sex cord tumor, it occurs in older females, then the patient is going to present to you as a case of postmenopausal bleeding. But mostly the 90% cases you have epithelial cell tumor, and in epithelial cell tumor, patient comes to you with very, very vague symptoms resembling the irritable bowel syndrome, right? Then let's talk about the most common route of spread. Now, the most common route of spread in cancer endometrium is direct spread followed by lymphatic, whereas the most common route of spread in cancer cervix is lymphatic spread. Now, everything which I wanted you to know about the lymphatic spread of cancer cervix, I have dealt in yesterday's session on the anatomy. When I was talking about anatomy, I had told you that the most common lymph node involved in cancer cervix is obturator lymph node, but the first lymph node involved in cancer cervix, the sentinel lymph node, is the ureteric lymph node. A very, very important thing which you have to remember is that both in case of cancer endometrium and in case of cancer cervix, if pelvic lymph nodes are involved, then the stage of the cancer is 3C1. If para-aortic lymph nodes are involved, then the stage of the cancer is 3C2. And if inguinal lymph nodes are involved, then the stage of the cancer is 4B. In other words, metastasis has occurred. Now, earlier in staging of cancer cervix, there was only stage 3A and 3B. The new staging of cancer cervix, it includes stage 3C, 3C1 and 3C2. Where 3C1 is pelvic lymph node involvement and 3C2 means para-aortic lymph nodes involvement, similar to endometrial cancer, right? Now, this is what you had to remember about the spread of endometrial cancer and the spread of the cancer cervix. Now, staging for endometrial cancer and staging for cancer cervix is very, very important. All of you are going to write that staging on a piece of paper and put it up on your walls so that you can revise it daily. Very, very important staging. In cancer ovary, for the FMGE students, I will not say that that staging is very important. Whatever is important, I'm going to tell you just now in cancer ovary. Cancer cervix, cancer endometrium, the complete staging is required, right? And for cancer cervix, you will have to go for the new staging, new FIGO staging of cancer cervix. Do not revise the older one. Just in case you are revising the older one, just remember that in stage 3 now there is 3C1 and 3C2, right? Then, in case of ovarian cancer, the most common route of spread is transcoelomic spread or the transperitoneal spread. Right? In case of cancer endometrium, it was direct spread. In case of cancer cervix, it was lymphatic spread. In case of cancer ovary, it is the transcoelomic or the transperitoneal spread. Now, if you are getting malignant ascites in a patient of cancer ovary, that means it is stage 3C. And if you are getting malignant pleural effusion in a patient of cancer ovary, it means it is stage 4A. Clear? So, ascites is stage 3C, pleural effusion is 4A. Second most common route of spread in cancer ovary is lymphatics. If pelvic lymph nodes are involved in cancer ovary, it is stage 2B. And if inguinal lymph nodes are involved, it is 4B. So, in all major gynae cancers, that is cancer cervix, cancer ovary, cancer endometrium, inguinal lymph nodes are involved in stage 4B. Clear? In cervix and in endometrium, pelvic lymph node was involved in 3C1. In ovary, it is involved in 2B. These are some facts which you will have to mug up. The third most common route of spread in cancer ovary is hematogenous spread. Clear? Now, diagnosis. In case of endometrial cancer, the investigation of choice is endometrial aspiration biopsy, which I told you is an OPD procedure, and it is done with a Pipley or a Vabra aspirator. Gold standard investigation in case of cancer endometrium is fractional curettage. Diagnosis of cancer cervix is same like CIN, and in cancer ovary also that you don't have to remember anything about the diagnosis. I hope these points are getting clear to you. Now let's talk about the staging method. In case of cancer endometrium and in case of cancer ovary, there is surgical staging. In other words, you do surgery first, and then after doing the surgery, the histopathologist is going to tell you the staging. Whereas in cancer cervix, like what you do in normal breast cancer or other cancers of the body, you will do the investigations, you will come out with a stage, and then as per the stage, you are going to do surgery. But it's the other way around in cancer endometrium and cancer ovary. In cancer endometrium and cancer ovary, you are first going to do the surgery, send the specimen to the histopathologist, and then the histopathologist is going to tell you what is the stage, and this is called as surgical staging. So in surgical staging for cancer endometrium, when I say that you are going to do a surgery, what surgery you are going to do? You are going to do a TAH plus a BSO, that is total abdominal hysterectomy plus bilateral salpingo-oophorectomy, and you are going to do lymph node dissection. That is the surgery which you do for surgical staging. Now, when you have opened the patient and you are doing this surgery, and if you see that the cervix is involved or any other structure below the cervix is involved, in other words, if the tumor is belonging to stage 2 or stages beyond stage 2. So from stage 2 onwards, that is whenever the cervix is involved or any other structure below the cervix is involved, then instead of doing TAH and BSO, you go for Wertheim's hysterectomy. So very easy. In case of endometrial cancer, for staging purpose, I'm going to do TAH plus BSO. But if cervix is involved or any other structure below cervix is involved, in other words, from stage 2 onwards, instead of doing TAH and BSO, I'm going to go for Wertheim's hysterectomy, right? Now for staging, I have done this much. Now already the surgery has been done. So if I ask you what is the management of endometrial cancer, you will say surgery we are going to do for staging, followed by a post-operative management, and the post-operative management of choice in case of cancer endometrium is radiotherapy. So for all stages of cancer endometrium, management is very easy. In all stages, you have to do surgery followed by radiotherapy. Surgery followed by radiotherapy. What surgery? TAH plus BSO. From stage 2 onwards, it's Wertheim hysterectomy followed by radiotherapy. right? Except, now this except many times question has been asked on it. Except in stage 1A1, grade 1 and grade 2. So except in stage 1A, grade 1 and grade 2. What is stage 1A? Stage 1A, if you remember, it is when less than half of the myometrium is involved. So it is not 1A1, actually it is stage 1A. So in stage 1A, grade 1 and grade 2, you don't do any post-operative management. Apart from this, in every stage of endometrial cancer, you are going to go for radiotherapy, right? So this is the management with the FMG students have to remember. Very, very simple management. And that is why I said management is going to differ for PG students and FMGE students a little. Clear? So many times FMG students, this answer is asked that in stage 1A, grade 1 and grade 2 of endometrial cancer, what is the post-operative management of choice? And the options given to you will be A, chemotherapy, B, radiotherapy, C, hormonal therapy, D, none. So your answer will be none. In case of stage 1A, grade 1 and grade 2, no radiotherapy is given, no post-operative management is given. Clear? Now, let's talk about the staging procedure for the cancer cervix. In cancer cervix, it is clinical staging, right? You will do all the investigations, you will do a colposcopy. Then apart from colposcopy, you will see whether the rectum and the intestines are involved or rectum is involved or not. So you will do a proctoscopy, you will do a cystoscopy. So you are going to do all the investigations. Earlier, it was said that ultrasound, CT, MRI, they are not done in cancer cervix. The recent guidelines are that now imaging is also a part of staging. So earlier when we used to discuss this topic, I used to make you people write that what are the investigations which FIGO has not included in the staging and for staging purpose. So I used to tell you that ultrasound, CT, MRI, they are not used for staging of cancer cervix. But now in the recent guidelines, all imaging investigations are a part of staging. CT is also a part of staging. MRI is also a part of staging, right? So you do a clinical staging, and how do you manage a cancer cervix? See, in cancer cervix, what you have to remember is radiation can be done in all stages. So radiotherapy can be used for all stages, that is from stage 1 to stage 4. You can use radiotherapy. So that doesn't mean that I will use, but from stage 1 to stage 4, radiotherapy can be used. The other important point is that in all squamous cell carcinomas, squamous cell carcinomas, they are not very sensitive to radiotherapy. So in order to increase the sensitivity towards radiotherapy, before giving radiotherapy, you give a drug which is called as a radiosensitizer, so that the sensitivity of the squamous cell towards the radiation is increased. In case of cancer cervix, the radiosensitizer which you use is cisplatin. Very, very important question. So whenever I have to give radiotherapy, before giving radiotherapy, I'm going to give cisplatin and then give radiotherapy. That is why it's better to call this procedure as chemoradiation rather than radiotherapy, right? So in case of cancer cervix, chemoradiation can be used in all 4 stages. Now let's talk about surgery. Surgery can be done from stage 1A1 to stage 2A1. So in all from stage 1A1 to stage 2A1, the management of choice is surgery, right? Although radiotherapy could have been done, but the management of choice is surgery. Now you will ask me, ma'am, why surgery? That is because in case of cancer cervix, ovaries are the least or the rarest involved, right? So cancer cervix does not involve the ovaries. So if you are doing radiotherapy, whenever you will give radiotherapy, ovaries are very radiosensitive. So the ovaries will get destroyed even in young females. So one of the age group for cancer cervix was 35 to 39 years. So in that age group, suppose I do radiotherapy, their ovaries will become non-functional, and at such young age, I do not want them to experience menopause-like symptoms. When I'm doing surgery, it is in my hands whether I have to remove the ovaries or not. So whenever you are doing surgery for cancer cervix in a young female, ovaries are left behind. That's a very important question. And that is why from stage 1A1 to stage 2A1, the treatment of choice becomes surgery. Here, exception is stage 1B3. As per the new FIGO staging, there is one more stage. Earlier there was stage 1B1, 1B2. Now there is one more stage, 1B3. And in this 1B3 stage, you do not do surgery. Instead of doing surgery, in 1B3, you will go for chemo radiation. Are you understanding? So from stage 1A1 to stage 2A1, the treatment of choice is surgery, right? But except stage 1B3. In 1B3, you have to go for chemo radiation. Clear? Now, what surgery are you going to do? In stage 1A1, in a young female, I am just going to remove a cone-like part of the cervix. That is, I'm going to go for conization. Whereas in older females, I'll do a TAH plus BSO. So only in stage 1A1 in young female, you can go for conization. In other words, cone biopsy or conization is not only diagnostic, it is also therapeutic, right? So here in stage 1A1 in a young female, I'm going to go for conization. And in older females, I will do a TAH plus a BSO. Rest in all the stages. In a young female, I will do radical trachelectomy. Be very careful of this term over here, radical trachelectomy. In all other stages, in young female, it's radical trachelectomy. Now, what is a radical trachelectomy? Radical trachelectomy is a procedure in which you are removing 80% of the cervix, right? And you are removing the McEnroth's ligament. Now, once you have removed the cervix, what you are going to do? You are going to stitch the uterus to the vagina. So, the uterus and the vagina will be stitched together. The intervening cervix, which was there in between, is removed. Right? That is radical trachelectomy. In older females, you will do a Wertheim hysterectomy or a radical hysterectomy. So that is the surgery which you do. In stage 1A1 in young female, conization, and in older females, TH plus BSO. Rest in all stages, radical trachelectomy in a young female, and in older female, Wertheim's hysterectomy or radical hysterectomy. Again, a word of caution here to all the PG students. This is not the management which you have to remember. You need to know a little more detailed management. This is only for FMGE students, the management part. From stage 2A2 to stage 4, the treatment of choice is chemo radiation. Very, very simple management for FMG students, right? This is all what you have to remember for management of cancer cervix, right? Now let's talk about staging and management of cancer endometrium. Like in, cancer ovary. Like in cancer endometrium, in cancer ovary also there is surgical staging. Now, when I say surgical staging, that means you have to do some surgery, and in stage 1 and stage 2, you do TAH plus BSO. In stage 3 and stage 4, you go for debulking surgery. Debulking surgery means whatever part you can remove, you will remove. The rest will be remaining like that. Maximum parts you will remove, right? The cardinal ligament, then the uterosacral ligament, maximum you are going to remove. So, you are going to do a debulking surgery. Right, that is for staging purposes, right? Now I'm going to send the specimen to the histopathologist, and the histopathologist is going to tell me what stage was the ovarian cancer belonging to. So now how are you going to do the post-operative management? Now the post-operative management will be that already surgery has been done. So now what I have to do? I have to follow it with chemotherapy, right? Remember, in endometrial cancer, the post-operative management of choice was radiotherapy. In ovarian cancer, the post-operative management of choice is chemotherapy. Why? Because all ovarian tumors are radio-resistant, right? This is a big contradiction. What happens is, ovary is very radiosensitive, but ovarian tumors, the ovarian cancers are radio-resistant. There is only one ovarian cancer which is radiosensitive, and that is dysgerminoma, right? So the management of ovarian cancer is that you are going to do a surgery. So for stage 1 and stage 2, TAH plus BSO, for stage 3 and stage 4, debulking surgery. And that was for staging, then followed by post-operative therapy, which is chemotherapy. Here also chemotherapy is given in all stages except stage 1A and 1B grade 1 and grade 2. In endometrial cancer, it was stage 1A grade 1 and grade 2. Here it is stage 1A and 1B grade 1 and grade 2. In this, no post-operative therapy is needed. No post-operative therapy is needed, right? So this is all what you had to know about management of ovarian cancers. Now, before I end this topic, you also have to know the case 4 which we had written there. So what is case 4 which I was telling you? Case 4 which you have to remember is that if a patient comes to you with post-coital bleeding, this is the only question which has come, which they are going to give, that a female comes to you with post-coital bleeding, what is the next step? Now, whenever a female comes to you with post-coital bleeding, and if you remember, I told you post-coital bleeding is one of the specific symptoms for cancer cervix, right? So whenever a patient comes to me with post-coital bleeding, I'm going to examine her cervix. If on her cervix, lesion is visible, lesion visible on cervix, in that case, I am going to take a biopsy from that area, and that is called as punch biopsy, right? But in case the cervix is appearing absolutely normal, no lesion is visible, in that case, first I'm going to do a pap smear, and this question has been asked many times. So, female comes to you with post-coital bleeding, next step. Next step means that nothing is visible. If anything would have been visible, they would have given to you that yes, a lesion is visible. Then the answer becomes very easy, that you have to go for punch biopsy. But if nothing is mentioned, it means that the lesion is not visible, and that means you have to do pap smear. Only if pap smear report comes out to be positive, then you are going to go for colposcopy. You are not directly going to go for colposcopy. Clear? So this was case 4 which you had to remember. So these are all the cases which you had to remember with respect to the gynae cancers. Last thing which I want to tell you before I conclude this topic is a very, very important table for ovarian cancers. In this table, you are going to write the name of the tumor, the histopathological finding in that tumor, and the tumor marker, right? So, epithelial cell tumor, the histopathological finding which you get in epithelial cell tumor is sarcoma bodies. And the tumor marker for epithelial cell tumor is CA125, very, very important. In granulosa cell tumor, the histopathological finding which you get is the Cal-Exner body, and the tumor marker for the granulosa cell tumor is inhibin. In yolk sac tumor, the histopathological finding which you get is Schiller dual bodies. And the tumor marker is alpha fetoprotein and antitrypsin, very, very important. In case of Brenner tumor, the histopathological finding is Ringcase crystal. In clear cell tumor, it is hobnail cells. In a teratoma, it can be an immature teratoma or a mature teratoma. That means it could be a dermoid cyst or it could be a mature teratoma. In them, whether it is mature, whether immature, the histopathological findings are teeth, bone or cartilage. Right? In Krukenberg tumor, the histopathological finding is signet ring cells. Right? Now, this table is very, very important. In tumor markers, there are 2 more tumors for whose the tumor markers you should know apart from the 3 which you have mentioned in the table. In case of dysgerminoma, the tumor marker is LDH or alkaline phosphatase. In dysgerminoma, it's LDH or alkaline phosphatase, and in choriocarcinoma, it is HCG, right? Many times question has been asked on Cal-Exner body and Schiller dual bodies, and often we try to forget. So remember, yolk sac tumor, S comes in yolk sac, S comes in Schiller dual bodies. Whether you call it as yolk sac tumor or whether you call it as endodermal sinus tumor, there also S comes, right? So whenever you are getting a yolk sac tumor, the histopathological finding will be Schiller dual bodies, whereas in granulosa cell tumor, it will be a Cal-Exner body. Now, what is this Krukenberg tumor? Krukenberg tumor is cancer ovary which has metastasized to the, cancer stomach which has metastasized to the ovary. So it is a metastatic tumor of the ovary, and most common site of metastasis is cancer stomach, right? So from the stomach, the metastasis has come to the ovary, and then it is called as Krukenberg tumor. Krukenberg tumors, they are always bilateral. They have a smooth surface. They don't have any adhesions, and because they don't have any adhesions, they are mobile. They have waxy consistency. The shape of normal ovary is maintained. So these are very important points about Krukenberg tumor, that they are always bilateral. The shape of the ovary will be maintained. The surface of the ovary will appear normal. The tumor will have a waxy consistency, and it will have a smooth surface. And just now we did that the histopathological finding in Krukenberg tumor will be signet ring cells. This is all what I want you to know on the gynae cancers, and this is all what I want you to know on gynae. This is rapid revision, right? So rapidly for revision, this is all what I want you to know. That does not mean that if you have studied gynae properly, you are not going to revise the entire notes. This is just that you don't miss out on the important points, right? I hope you are going to take full advantage of today's session, and if you liked this video, do not forget to share this video with your friends, and do not forget to press the like button, and also to leave a comment in the comment box. Please keep studying, keep revising these notes, and when you are revising these notes, please revise them loudly, so that these lines, they get fixed in your mind. If you get any question from whatever I have taught you today, at least you don't get that incorrect, right? So keep studying and keep revising. All the best for your exams. I'm going to see you soon with a rapid revision in OBS. Thank you.